This is Min Chang. I'm one of the cardiologists here at Methodist Hospital. I'm going to introduce our grand round speaker, Dr. Jonathan Leipsic, who just gave a terrific lectures and role of CT in mitral valve and tricuspid valve intervention. Jonathan, you're from British Columbia, Vancouver.
Yes.
Can you tell us a little bit about your background?
Sure. Well, first of all, thank you for the opportunity. I really enjoyed presenting here this morning amongst friends and a great institution. So I'm a radiologist by training, which is interesting always, as I do almost exclusively heart and lung imaging. I am appointed in the Division of Cardiology and drive the cardiac CT and MR practice at UBC. For me, it's been a tremendous opportunity, and what I tried to highlight today is the ways that non-invasive imaging can help us better understand how to perform procedures and help us improve clinical outcomes when performing procedures by using important non-invasive baseline data to discriminate those who are likely to benefit and those that are likely not to benefit from these procedures.
Yeah. Well, your work has been seminal in applying CT for transcatheter aortic valve replacement. And one of the major impact is that you use imaging as a clinical tool to determine outcome, which is very unusual for the field of cardiovascular imaging, and certainly don't want to offend any radiology colleague, very rare in radiology's community. How do you first get interested in doing clinical trial using CT?
Well, for me, when I started doing cardiac imaging, many people said, at the end of the day, this is going to be done by cardiology, and what role are you really going to have? And I've never really approached my life that way. I always feel so blessed to be able to do something that I enjoy and I find interesting. And I went through my training to try to help patients. And what I found is with cardiologists is they expect a lot. They expect a lot for their patients. And you know what? They're right to expect a lot. I also have learned from cardiologists is that if you work incredibly hard and you try to help advance knowledge and help the patients that the cardiologists are serving, that we're all collectively serving, they'll be very welcoming. So for me, I saw just meaningful opportunity in cardiac imaging in ways that for other imaging I just didn't see those opportunities. Opportunities to better understand atherosclerosis, better understand risk of myocardial infarction, mechanisms of myocardial infarction, and then in the structural space, a very tangible and meaningful way to use what I realized to be, I think, the best non-invasive anatomical test to understand cardiac anatomy in a way that was very difficult using particularly two-dimensional echocardiography.
Absolutely. So do you see any role of CT in providing some type of functional information in the future?
I think the opportunity for functional analysis is there. In the coronaries, it's already here in clinical practice, not pervaded everywhere, but we use non-invasive FFR through computational fluid dynamic derivation of fractional flow reserve from a resting CT to adjudicate the hemodynamic significance of stenosis, to help inform percutaneous intervention, to understand those that are likely or not likely to benefit. And I think in the valvular side, some of the great work being done by you and your group around 3D modeling and 3D printing to understand the impact of interventions or the need for interventions will be really helpful. And then beyond that, looking at CFD and solid mechanics for valvular disease to better understand patient-specific physiology and hemodynamics beyond the anatomy. I think we're on the cusp of that, if not there yet.
Yeah, great. A more technical question is, for valvular imaging, we usually have to do multi-phase imaging. How has the latest innovation in CT technology enables such analysis without giving patient too much radiation dose?
Yeah. Radiation doses obviously always has to be a concern. Most of our interventions, though, are being done on patients that are if not elderly, certainly over the age of 55, for whom radiation exposure is only, I think, a modest concern, given that they're being evaluated for severe valvular disease or extensive coronary disease. When it comes to the coronary evaluation, as you know, our radiation doses are at historically low levels because we typically use either high-pitch helical acquisition or prospective axial step and shoot triggering. For the valvular disease, what we find is that if we are imaging, most of these patients can be imaged at lower tube potential, 100 kbp. We use some dose modulation at times, but even if with whole heart coverage scanners or the dual source scanners, we're finding that we can get full cardiac phase analysis of the entire heart for doses on the order of 7-8 millisieverts, which I think, given the baseline condition that these patients are suffering with and the treatments that we're determining, I think that's an acceptable, more than acceptable dose exposure, given the richness of information that's yielded from the CT. Now, over time, we may find that we can actually narrow the pulse acquisition, as we've done in the aortic position. In the mitral side, we still push for an entire phase because we're really needing to understand, the dynamism of the mitral annulus, where to measure it, how to best size, and the risks that come with cutting corners to save a little bit of dose, I think, are much greater than the benefit of cutting that marginal dose down.
So the message is important, for such a complicated intervention, you really want to get the most data as possible in order to guide your therapy.
That's our practice, especially at the early stages of a lot of these interventions. As the interventions mature, there's the opportunity to focus in on what proves out to be the most important information.
What do you see the next wave of technological innovation in terms of catheter interventions and how CT can help?
Yeah, I think that's a really good question. I think on the mitral side, there's so many questions. Is repair better than replacement? Should these patients be treated with severe FMR and LVEFs below 35%? Do they derive benefit from treatment, period, repair or replacement? I think, though, that CT is so well established now, where the real opportunities are going to be is to then move into patient-specific modeling. Some of the stuff we talked about earlier about predicting who's going to have resolution of the MR, predicting and understanding mechanisms of paravalvular regurgitation in the mitral position, understanding mechanisms and risks of LVOT obstruction, also looking at structural valve degeneration and leaflet thickening, whether CT should be done routinely. And we'll hear some exciting data, waiting to hear this exciting data presented at the ACC about the clinical impact of leaflet thickening. And so the role of CT may in fact grow in that space if shown to be clinically relevant, to better understand mechanisms of risk and mechanisms of structural valve degeneration.
It's great. It's kind of remind me of what you say earlier about you went to medicine to help people. I think, in a sense, we use technology not only to take beautiful pictures and allow our colleagues to perform the procedure, but ultimately make an impact in patients' outcome. And I think CT, I agree with you, is one of the best tools in terms of generating patient-specific information to help the procedure, right?
Yeah, no doubt. I think that the days of simply imaging for the sake of imaging or imaging for technical feasibility or even accuracy are gone. We have to focus on the right side of the table from the Freibeck and Thornberry clinical decision-making paper, right, into therapeutic impact, societal impact, economic impact. We have to do things more efficiently, more cost-effectively, and improve outcomes and inform and provide imaging that actually alters clinical decision-making in a positive way.
Right. And in a sense, there's a lot of turf war in a lot of institutions between radiology and cardiology, and I think we need more people like you who reach both worlds and ultimately to push the field forward.
No, you're kind to say that. I mean, I think that, in my opinion, turf issues only get in the way of best practice and best patient care. And that's in no one's best interest. It's never in the best interest of the hospital, never in the best interest of the Department of Radiology or the Division of Cardiology. And it's certainly not in the best practice for the patient, nor, I think, our souls as physicians. We took a Hippocratic oath, and our oath is to our patients. And so I think if we work together, we can do great things for those patients rather than trying to, having silly arguments around issues around resource allocation. We should just drive the field forward and help people. That's what we set out to do.
Well, you did a lot as a president of the Society of Cardiovascular CT, and we really thank you for that.
Thank you
for coming to Houston.
Thank you so much for the invitation. I really appreciate it.